right, welcome back to Outside the Box, an EMS podcast driving our clinical performance here in the city of Sugarland. I am Kevin, your host, and today I am pleased to be joined by a special guest from a neighboring agency. We have Chief Atripaldi with us today, and we'll get to his background and get to learn a little bit about you here in a moment. But we're very excited to talk about ventilation today.
Good.
And this is fun, is when we started talking about this topic here at a fire department, I said ventilation. I have to specify that we're not talking about letting smoke out of buildings and releasing the heat, that we're talking about ventilating our patients today. That's going to be our topic. And before we dive in there, Rob, why don't you tell us about you, where you're coming from, and some of the background you're bringing to this conversation?
Yeah, man, well, I grew up in Portland, Maine. I was a hockey player for many years and got out of school and went in the military. And so the military is my background. They really gave me a great foundation for my growth in the medical field. I was a combat medic in the 80s up until 92 and spent time in many countries and had great training. It was less concept and more just task oriented. Went to paramedic school in 1989 and so been around a little while and been in EMS since 1984. Spent 16 years with the Portland Fire Department, Portland, Maine, as a firefighter paramedic, raised to the rank of lieutenant supervisor in that department, and then relocated to Charlotte, North Carolina, and took on the clinical coordinator and lead educator role for Charlotte-Mecklenburg EMS through the Center for Pre-Hospital Medicine, which is the hospital there in Charlotte. And then from there, here I am, Fort Bend EMS, after some stays here in Texas and figuring out how to manage the weather.
Nice. Have you figured out how to manage the weather?
No, sir. Not at all. Not even close.
This summer's really making it a fun little challenge.
Yeah, no doubt about it.
It sounds like a good chunk of background for you. Some education, some practical medicine that you've applied. This sounds like quite the spectrum of experience.
Yeah, been an educator and leading, coordinating paramedic classes since 1992. I think I've got 23 under my belt that I've been the coordinator for and or lead educator. And so some history there of mistakes and some success. So that's my background on that.
I like it. Let's pull this into our clinical topic today, like we talked about ventilators. Probably have a little experience with ventilators.
Yeah, I love ventilators. Yeah, some history with flight medicine and critical care transport, pediatric and neonatal and adult. So yeah, the ventilator is a great tool. I'm excited. I think I heard you guys are getting ventilators.
We are in the process of our deployment and implementation, and actually this piece of education gets to be a component of that to get our providers spun up for adequate ventilation in the field.
Going to tell you that's really good that you guys have stepped off and decided to get ventilators. I'm just curious, maybe we can just chat for a second about this. What were you using before you got the ventilators?
We were using BVMs.
Okay.
We've recently had one ventilator out with our supervisor for mechanical ventilation, but we've been using a BVM classically for ventilating our patients.
Well, I think that if we want to chat about getting a ventilator, I think everybody that at least is a basic EMT or above has really even a first responder has been given a ventilator. They've been given ventilators and told how to use ventilators. Ventilators have been in the field for some time, probably even before I was in EMS.
But no, Rob, ventilators are expensive.
Yeah,
they're difficult to put on every truck. But you're saying that every provider has their own ventilator.
Yeah, everybody's been given a ventilator. Now the question is, do they know how to manage the ventilator and use it? There's some settings on the ventilator. Usually the 3 settings that you're going to find on any ventilator, are rate and volume and pressure. So those 3 components ring true through all ventilatory support. And I think that you and I have had a little conversation about this, and I think it's a good time to bring this up, which is, what is a ventilator? And a ventilator to me is the person that you hand the bag valve mask to. That is your ventilator. We've had ventilators for a long time now. We let's put this in perspective and see if we can get it back to a basic level. And when I say basic, I'm not talking about what your patch says or what your level says. When I say basic, what I'm talking about is, do we know how to use a ventilator? And then let's take that into a different context. Do we know how to use a bag valve mask? And if the bag valve mask is truly our ventilator, then anything beyond that, like a mechanical ventilator, I think that's what you're talking about, getting mechanical ventilators. Anything beyond that is a step above, which means that I still have to be extremely proficient at the level of my ventilation support, my bag valve mask support. And when we in EMS, and I'll stand and I'll raise my hand and say I'm totally at fault as well, which is we tend to decide that the ventilator, and when I say that, are we okay when I say ventilator, we're gonna what I mean is a bag valve mask effectively used. When we say ventilator, we tend to tie that with an EMS level. If it's a basic EMT, they know how to use, quote unquote, a bag valve mask. That may be true, and there may be a time that they do know how to use a bag valve mask, but is that true across the board? And is that true on every single situation? And if it's not true, do we assess that and decide, hey, this person that's, quote unquote, my ventilator may not be the best decision for me to make, allowing them to be the ventilator when I'm not meeting the patient's needs. When you get a mechanical ventilator, let's just say you got your mechanical ventilator today and you employ them in the field, and today you and I are working together and we've got this mechanical ventilator and we put it on the patient. Let's say that we put it on the patient poorly. We didn't put it on effectively. We didn't put the headgear on, or we didn't effectively put it to our supraglottic device or our endotracheal tube. And we put it on, and what the ventilator is going to do for us, the mechanical ventilator, is going to beep and sound and tell us all kinds of things that we've done wrong that we need to troubleshoot. But historically, with me and working in a fire department specifically, I'd take that bag valve mask and I'd say, well, I'm the paramedic. And as the paramedic, I have a lot of high-end skills that I get to perform and I have to perform. So I'm going to take this skill that's called ventilation, and I'm going to hand it to somebody that I haven't vetted and I don't know that can use it. And I'm going to say, good luck, best wishes, this is your level skill, and you should do it. And I walk away from it.
And who is that person? Who do we hand that to?
Well, I'll just talk about for me historically.
Let's be real. Industry, Rob. In the industry, who do we hand the BVM to?
Lowest common denominator, a student, a first responder, the new guy on the fire department or new gal on the fire truck. That person is the person we go, here, you're burdened, saddled with this piece of equipment. And sometimes they're happy, they get to watch everything and they get to sit there and they get to be the gawking Gary. But in reality, is that truly who we should have handed that to? Who is the most effective ventilator in that team? I don't know who it is. It may be that basic EMT. It may be the anesthesiologist. It may be you. It may be me. I don't know who it is until we validate and that ventilatory skill in advance or validate it on scene to say, hey, you're doing a great job. But right now, most of the time, I'll just tell you historically for me and us in the industry, we hand it over. I could put a screen up and not look at you again, and I go on about my business doing all kinds of really cool things. And I never reassess that unless a number beeps at me or an SPO2 says something. Then I tell somebody, hey, you may want to readjust the airway, or you may want to check your seal, because I know the buzzwords. Yeah. And they've heard the buzzwords, so they go, oh, yeah, I got to reposition the airway. I got to fix my seal, whatever that looks like. And then I go, okay, you've done what I asked you to do because you know the buzzwords, and I drive on with the call. And the sad part of it is, historically, I think we've failed patients with ventilatory support, but we've done a really good job getting IOs and giving meds on time and on task. Yeah. And we've recognized bad rhythms, and we've done some really cool things. But when it comes down to our ventilatory support, I guess I'm going to use the word failed. We've failed in this industry, and we failed. I said I was an educator for many years. Still am an educator, but in paramedic classes, I did that. I said, hey, as long as you can pass the National Registry BVM station, which just means I can put it on, I can grab the mask. I know how to put an oral pharyngeal or nasal pharyngeal area in, and it looks like the nose pieces in the nose and the chin pieces in the chin. I'm going to test you out. I'm going to just check your boxes, and we're going to go ahead off to traction splinting now. And we don't really say, hey, provider, let's fix this right now. How many people in our industry, I know this is a two-way conversation, but realistically, how many people in our industry can you say, man, when all the chips are down, that guy can ventilate anybody? That gal can ventilate anybody. We don't do that. We say
that's the title we put on that person. We don't revere it that way.
no. We say, hey, that guy can get a line on anybody. That life-saving IV, but we don't say the person that's ventilating is really the person that's our lifesaver, and are they effective and are they competent at doing that? And I'm not dogging them if they're not competent. We as an industry have set people up to just kind of check a box and say, because you verbalized to me what the buzzwords are, then I assume, which is a really bad thing, that you can ventilate. No, what you can do is you can pass a test to manage a bag valve mask, but you really don't have the skill set to ventilate.
I agree with a lot of this stuff. Let's recap a few of these things because we got a lot of good foreshadowing in here. I'll let you know that it was foreshadowing to some of these topics that we'll talk about where education doesn't necessarily address this in the regard that we're going to talk about. The ventilation is important. Breathing is important. I myself am a big fan of breathing. I try to do it every day.
Me too.
I make time in my schedule for it. But we don't necessarily give it that regard in education. We'll talk about that in a minute. We'll talk about who we hand this off to and how we can be a little bit better. We'll talk about the feedback and validating. I like your word validating. We keep using the word validating. And we'll talk about that as a specific discussion point as we get into validating, that you're right. We can't have global validation 100% of the time before we go in. We can just throw up our hands and say, oh, tough luck. Or maybe we pay attention to what's going on. We validate in the time. Let's talk about, real quick, let's recap this as we before we head into the curriculum too deep. It gets introduced at a very early level, and we talk about it being introduced at the BLS level, but even then, you can go take a 16-hour CPR course,
right?
And BVM ventilations are introduced there.
Right.
So you're and this is right. CPR card's a certification. It's not a license to practice medicine, but it's a skill that's introduced there. And I think we kind of, as an industry, discount the need to continually revisit this topic and scaffold the performance level on top of it and grow. You handle the CPR class. You got a CPR card. You're good.
Yeah, you should be able to use it. Hey, did you get BVM in your CPR class? Oh, great. Then you can manage this.
Right. You've done some research on this. You've looked at this. At the BLS level as an industry, how much time do we really spend on airway and ventilation management?
So let's just start with a basic EMT class. So we're gonna give a basic EMT class, and I say that from a basic EMT because as we escalate in our levels, we as educators, we as an industry, we just say we accept that. Well, you've already met that criteria, so I don't have to even worry about it any longer. So I looked at a basic EMT class. So we're going to run a basic EMT class, and we assume that airway, breathing, and circulation are very important. So we spend some time on we don't spend a whole bunch of time on CPR because you brought a CPR card with you. Mm-hmm. So I don't have to validate your CPR. I just have to see your card.
What's the most important intervention in cardiac arrest, though?
Airway management.
Oh, I'm going to go one further then.
Go ahead.
And we're going to say the chest compressions, but we're going to discount it because you've done the CPR card.
But you have that card already.
Right? We can write it off to the side. So, maybe this is a good point to clarify. When we say basic, and this is from our discussion earlier, we'll refer to basic as pertaining to an EMTB level skill set. But we need to repackage how we use the word basic, and we're going to say fundamental or rudimentary. This skill set is a rudimentary skill and not specifically tied to a skill level. So when you hear us talk about basic in these conversations, yes, we're talking about EMT basic pertinence. But for the most part, we're talking about rudimentary, fundamental things that do not necessarily have a home in any one specific skill level.
Yeah, let's run that out. Let's just run some time frames out. So I take a basic EMT class, and in that basic EMT class, I have an airway section. Mm-hmm. And usually, EMT classes, oftentimes people have other schedules, so we teach them at night. Mm-hmm. And so I'm just looking at a 6 to 10 o'clock at night class. And we're going to do airway tonight. Tonight's our airway night. Now, we're also going to do bag valve mask and ventilatory management that night. Is it really ventilatory management? Is it the outcome of really ventilating a patient? Or is it, I'm checking a box to assure that you know what a bag valve mask looks like, and you know where to put your hands, and you know where the tip of the nose and the bottom of the chin go?
So the technical competence versus the conceptual competence discussion.
Two totally different places, right? And we've accepted the technical competence in this industry. Mm-hmm. And so we give you this class, and in this 4 hours, we're going to teach you how to put together an O2 tank with a regulator, a gasket. We're going to tell you how to put a nasal cannula on and what flow rate to do. We're going to do non-rebreather, and we're going to do bag valve mask technique. And we're going to, at the end of the day, we're going to wave a bag valve mask around, and we're going to say, okay, everybody pass the bag valve mask section because you all put your hands in the mask in the right place and you all drive on. And the good news for EMS is we're going to validate that repetitively throughout your EMS career. No, we're not going to do that. We're not going to validate it again. We're not going to ask you again to prove that proficiency. We're not going to ask you to do it again because you've already, quote unquote, proved it at the basic level. Now, let's look at a basic EMT curriculum. We're talking about all airway management, including bag valve masking, is a 4-hour block.
4 hours. So
That's
an evening based on the sample schedule.
Right. And then let's just fast forward. Let's just say you got through your basic class, you went through an advanced class, and you're a paramedic, and you got through you got to the paramedic level. When you got to the paramedic level, we don't make an assumption that you know how to use a bag valve mask. We say, hey, you know how to use a bag valve mask. Let me back that up. We say you know how to use a bag valve mask because you're a basic EMT, and that's good. So we want to add to that bag valve masking. We don't check you for proficiency. We want to add to that bag valve masking with supraglottics, endotracheal intubation, cutting people's necks open. We want to get you these really cool skills and techniques, and we don't even go back and say, hey man, can you really effectively use a bag valve mask?
So totally matter of opinion in this question. But do you think, I know what I think, and I think I know what you think. So nice little lob here. Do you think it would be value? Like we're trying to do the scaffolding. We're trying to put new things on top of what we already know and existing knowledge. But we kind of missed the spiraling piece of coming back to it. Do you see value, Rob Atripaldi, in advanced EMT paramedic airway management curriculum has its own section on effective ventilation with a BVM as part of the curriculum, not even necessarily a review of you should know this, but here's your base knowledge and it is so important. We're going to cover it again. And one of my favorites when you get people that already know this, but show me,
right?
Or you get the really arrogant ones and it's I already know this. The story I'm telling myself is that you're then choosing to not do it the way you know because you must know better than this. But we take this in this paramedic class, and it is I'm a hotshot paramedic now. I know better. I'm better than somebody else. But we never revisit this concept. Do you see the value in that just being part of the curriculum is you do it again?
Well, you know the answer is going to be that's a huge lob with a beach ball. We spend a semester, a whole module in paramedic class doing airway management. It's called the airway module. Mm-hmm. Now, most of that module is spent on advanced skills, more invasive skills. If you really want my honest opinion, I'll take the lob and I'll tell you this. I would love for us to spend a whole module on can you effectively ventilate a patient with your hands?
I want to point out that this is a semantics game because I love semantics. You learn ventilation in school and there's the ventilation learning objectives, but you keep saying effective ventilation. And I think that's what separates out the technical competence is sure you can technically ventilate to the concept of ventilation that you can effectively do it. And we'll talk about the objective-based part of it, but the goal of using a BVM is not to put a mask on a face and tilt the head back. And when you crank it back, we do that terribly too. We just crank even further and further until you're anyway. And we just squeeze this bag. Like that's not the goal of this. We shouldn't be finishing that module with that being what we take away. That the oxygenation component of it, the actual physical ventilation to eliminate waste out of this person. We kind of skirt past that. You're right that it's the checkbox doesn't say oxygenate well. It says use your EC clamp.
Right.
Yep, you did.
Yep.
It says put the nose in the nose. Yep, you did. Squeeze the bag with one hand while holding it. Yes, you did. But it's never a talk of you did those things and your patient's oxygenation was still 68%, and you didn't effectively ventilate. Right?
I'm going to go back to our basic versus our paramedic in the levels. As a basic EMT, if you're a basic EMT, you know this. You're taught, hey, you should check ventilation. You should check rate. That's what we say. If it's, depending on your book, if it's less than 12 or greater than 20, greater than 24, whatever that is, you need to get in and you need to get in with a bag valve mask and bag valve mask that patient. Is that true? Because when you get to paramedic level, they say, oh, you want to take into account rate. You want to take into account tidal volume because you can cause damage with tidal volume and effectively not ventilate with limited tidal volume. And are you effectively giving the right pressure, right? And on your mechanical ventilator, those are going to be your three components that are going to need to be managed, right? Rate, volume, and pressure are the three things you're going to need to manage. Well, that's awesome. We got little dials for that, and it beeps at me. But do I really look at my basic EMT or whoever's running that bag valve mask to effectively determine, are you ventilating this patient? Are you meeting their rate requirements? Are you meeting their pressure and volume requirements? And if you're not, am I going to correct you? Mm-hmm. Because even now, when I tell our providers, I say, hey, you need to really be on top of whoever's quote unquote ventilating. You have to be on top of them. And the comment is, well, I don't want to upset them. They're already a basic EMT, so they should know how to do that. So I shouldn't have to check them. Well, who really on this scene has had the most airway training? And I'm not talking ventilatory training, just airway training. Mm-hmm. The gentleman or the gal with the 4 hours of training that went through an EMT class, or the person that went through a module of 80 hours plus clinicals to prove that, an OR rotation and an ED and a pre-hospital rotation, is that the person that's most competent? If we put our cards on the table on a scene and we've got a patient that requires ventilation, and we all throw our cards on the table and say, here's who I am, here's who you are, here's who you are, who really has the most skill? I'm going to just say at face value, and again, at face value, it's going to be the paramedic. The paramedic's going to have the most skill. That's my hope, that paramedic has the most skill set. Well, then if the paramedic has the most skill set, then why would I hand this piece of equipment, this ventilator, off to a basic EMT or somebody? We have first responders or just CPR trained folks that we say, hey, you can have this. Is that in the best interest of the patient? And if it is, then okay, then we're going to have to accept that. If it isn't, and I don't believe it is, I believe the person that should be the ventilator should be the person with the most skill set in airway management with a history of validated ventilation. If we take this mechanical ventilator and you roll them out to the field, I assume your paramedic's going to get some training on mechanical ventilation. Let's take your first responder that just showed up on your scene. They just got validated as a first responder. Or maybe a police officer shows up and says, hey, I am a basic EMT too. Would I take that mechanical ventilator and would I hand that mechanical ventilator to that police officer and say, officer, you've passed a basic EMT class or you're CPR certified. Here, you get to run the ventilator. Mm-hmm. What do you think? And what if I just put it up at the head and I said, best wishes, good luck, because you've been trained in ventilatory management, haven't you? And I go and do my thing. Would I be surprised to find that my patient is hypercapnic and their SATs are not good and my patient's outcomes are not positive? That's happening every day. We're doing that every day. We're handing these bag valve masks off to folks that not by their own fault. I take responsibility as an educator because I taught these folks and said, you check the box to see EC clamp and all these other things. And I never validated, nor did I validate on scene. Even if I hand it off to somebody, do I turn around and do I look and I say, hey, you right now are effectively ventilating this patient. You're doing a great job. Don't change what you're doing. Or do I say, well, it's a basic EMT skill, so I'm going to just drive on and continue on my path as a paramedic.
I really like your bringing the police officer in to this example. Not even the ventilator. We're not going to hand this police officer a BVM, right? I'd love to teach them how to use a BVM.
Sure.
I mean, they're there much earlier. They can get this patient action. Whole nother discussion. We can have that discussion another day. But I think that you're right. That's a very valuable point. But we do regard it the same way. We make a lot of dangerous assumptions, I guess, is what it is, that we assume. But you're right. We take a police officer that's an EMTB versus an EMTB here in the fire department or in the county service and somehow regard them differently, but they've had the same education.
Right.
And I think that's a very valuable highlight to make, is that it isn't the certification that really matters. Because like we talked about, you go to the paramedic level and there is no additional BVM ventilation training at the ALS or intermediate level.
No, it's technical skills.
So really, is the paramedic any more highly trained in this specific domain than an EMTB, right? And it's from the initial education program, right. I would contend no.
I would agree.
And it's what comes after the initial education program. And that's, I think, man, I love it. And you didn't even bring this up in a previous conversation.
Step back.
It gets me really excited to say that, yes, an EMTB in the police department, or we have them in public works,
right,
that we put them through some of this education to expand the workforce in a high demand time.
Yep.
But they're going to be viewed differently in another city department, but certified as an EMTB.
Sure.
Versus an EMTB here that's in the fire department and doing, I think it's because we also put the assumption on, well, if you're here, you see it and you know, and you have more competence. But from our level, it's, have we really provided you the opportunity to refine this competence and to validate this competence ongoing? So I interrupted you. You want to?
No. I think I'm an analogous kind of guy, because I think sometimes we can make mind connections with when we paint a picture or see a picture in our head of a scene. So I'm going to paint a scene for you. You're the paramedic in charge, and you've got a student on your truck, and they're there for advanced level training, and they want to start IVs today. And you've decided that you've not seen their IV skills all day long. And our first call is, it's critical that we get this IV because there's medication that this patient requires that's important for them to get. And I need that IV. So I say, you know what, as whoever this trainee is, I say, hey, go ahead and start the IV. And I hand them the catheter, and I hand them the bag, and I hand them the tubing, and I go do what I want to do. I get some stuff done, and I come circle back around to them, and I say, hey, provider, trainee, how'd you do with the IV? And I look down, or I don't even look down. I don't look at the IV. They've been trained in school to start IVs. So I look down and I see that there's a catheter under some tissue with a bag connected to it and some tubing. And I'm like, well, they've been trained to do IVs. So I'm going to make an assumption. Again, we're making assumptions here, where the IV is not going to kill the patient, but the lack of ventilation will. I make an assumption that, well, you've got a great IV, and I'm going to start pushing all my meds through it. And is that a valid decision for you to make, to say, I'm going to trust this whoever to start my IV because they have been certified to start IVs, and I'm not going to go and validate that? You know what I would do? The reality is I would never do that. I would go down and look. I would say, hey, did you get a flash? I would validate that IV. I would make sure there's blood flowing. I can push things through it. There's no issues at the site before I'm going to push a med through that. But unfortunately, Kevin, what we do is, again, I did a 4-hour lecture on this, that we hand the bag valve mask off like we do the IV catheter, and we say, I trust you.
Let me know when there's a problem.
Right. And you know what? If I'm the patient lying there, if we could do a Holy Grail skit, the Monty Python, the patient should sit up, look at this person, and say, is this person really the person that should be doing this? And look at you and go, is this person the really person that should be doing this? And you should be able to say, you know what? I'm not positive, because if that's me laying on the ground, bro, I sure want somebody to be able to manage my airway. Yeah. Everything else for me besides airway really is important. But if I can't manage the airway, our acidotic cliff hits really fast, and our morbidity and mortality escalates exponentially. And in your department, my department, departments all over the country, we look at this skill and we say, awesome. I wonder what our real ROSC rates would be. I'm being real with you, sir. If we could really effectively ventilate, we're going to throw, because we don't do it well, we're going to get a mechanical ventilator. You've already failed the system. Because if you can't use it with your hands as a backup, then that piece of equipment is really just a piece of equipment that should sit on the shelf. And that's my honest answer. Historically around the country, there have been people pushing this, up where I came from in Maine Institute of Medicine, Kevin McGuire had been pushing that for a long time. He was one of the, spearheaded this, going, we are not effectively managing patients. Went to North Carolina, Thomas Nagel down there at Center for Pre-Hospital Medicine said, we are not effectively managing patients, excuse me, and we need to effectively manage patients because everything else has no value. And, people scoffed at that. That was back in the 90s and 2000s. People just scoffed at that and said, you're just wasting time doing things that people have already been certified to do, and we need to focus on more important things, like we just got these really cool humeral head IOs instead of Jamsheeties where we don't have to do this anymore. We're going to put our time, effort, and energy on fentanyl. Fentanyl's rolling out. Ketamine. We're going to put our time, effort, and energy into that. Well, my ketamine's not going to work. My fentanyl's not going to work. That eye has no value. Your monitor has no value. If the foundation is the airway management and ventilation, then we've set ourselves up for failure. I'm stepping out and probably going to get some emails, but I think this industry we set ourselves up for failure in the way we've tested and not validated. You don't take a firefighter that walks in your door that says, "Hey, I was a volunteer level 2 firefighter from South Bend, Indiana. I want to join your department. I've got a certificate," and you say, "Great. Oh, you were also a lieutenant. Well, then take that truck, take those 3 folks, and you go run the next fire." You wouldn't do that. You would go, you'd put them through an academy, you'd validate their skills. But you know what we do when we hire our paramedics? We say, "Congratulations, you've got a certificate. Welcome, good luck, best wishes, enjoy your career." And frankly, at this point in time, I'm forced to go back and say, as a leader in EMS and in my service, this is a tough thing to say. I don't care if you can get anything else done on the way to the hospital. If you can effectively manage that patient's ventilatory status and you can effectively manage their circulation, everything else for me is a bonus. Mm-hmm. But if those 2 things aren't secured, then we're already in trouble with this patient. We say it from basic EMT. Well, when you get in trouble and you're not sure what to do, airway, breathing, and circulation. Do you really do that? Or do you just look down and say, Thomas or Jennifer sitting at the airway looks like they should be doing the right thing. I see the CE clamp, I see their hands in the right place, and I see their hand over the bag valve mask, and they look good doing it. And that's all they do. They really do look good doing it.
Mm-hmm. So it sounds like we're just being really cynical and beating up on ourselves. And I think we've kind of driven the point home that we have undervalued ventilation, undervalued BVM as a management technique for ventilation. And I agree with you that the ventilator is a very fancy tool, the mechanical ventilator. Very cool features on this. Very good tool. A lot of the feedback, that's what I'm really excited about, is you get all of this feedback on what the patient is doing interacting with this machine. Let's also take a moment to appreciate the interface between positive pressure ventilation and the human body.
Yeah,
the human body does not doesn't like it, right? Even when we go into the vent wing in the residential care facilities and we take somebody off of their vent and we put them on a different vent, the body doesn't like change.
Right.
So this interface in itself is a challenging dynamic to navigate. And then we discount the attention we need to give it and the appreciation for it. And one of the things that we like talking about is we're looking at alarm remediation while we're training on our ventilators, is that if you have an alarm and you disconnect the ventilator and turn it off and put it away because the alarm's really obnoxious and you just bag them, you got rid of the feedback. You didn't get rid of the alarm. The alarm exists.
Right.
And I hear that ring through in a lot of the comments you're making, that the need for rate management, volume management, pressure management, they all exist already. All the things we've just incorporated some technology to do in a bit more refined way, putting feedback, they already exist. The need for the pressure oxygenation, the concentration and pressure of oxygen is there. We just get to be more precise with the machine. The rate and volume control and playing with the minute volume is already there. We already do this.
Yep.
This was a fun thing to see some of the light bulbs with some people that here's how we're going to play with rate and volume to affect the minute volume and the elimination.
And sometimes it's less than 12 that we were taught in EMT school.
We were taught, we'll take a moment to talk about reference ranges because I could go all day.
Yeah.
But to see some of our fighters with that you get the patient who's end title 70, well, I'm going to bag them faster. It's great. You already understand minute volume. You get it. It's already there. We just added you a new machine with some new technical pieces. So we're not trying to be cynical and beat up our industry. We're trying to highlight this need of where we need to focus some attention. Mm-hmm. And I see it in turn as an opportunity. Here's an opportunity to make such a difference in this patient that we have not given much attention to, right? As the third child in my family, I could recognize not always getting the attention that I think I should get. Yeah. There's ventilation with the BVM, right? And you as the person are the ventilator. Yeah. The machine we call a ventilator is the device by which we do it, but I still have to control it. The BVM is the device by which we do it, but I still have to control it. Let's take this opportunity to kind of shift gears into what do we do with this? So let's talk about respiratory failure, because this is another thing. I come out of school and I remember being young. Respiratory failure in my mind was they stopped breathing.
Right.
But we have a different term for that. What do you call that when somebody stopped breathing?
We call it apnea.
Right. In respiratory failure, somebody's still breathing.
Yeah.
They are.
Yeah, they have an intrinsic, self-intrinsic rate that where one of those 3 components that you're going to get to play with, they have a rate issue, or a volume issue and or a pressure issue. It could be all three. It could be one of the three, because those are really, that's the triangle for us. And the unfortunate part of the triangle, no stones being thrown, is we only taught one part of the triangle in the basic EMT, and we added a couple other components, but we didn't talk about all three as a concept. Mm-hmm. That's a concept. All three is a concept to ventilatory management. We just did 24 and 12, greater than or less than. You throw a bag valve mask on and try and keep between 24 and 12, but we didn't talk about pressure and we didn't talk about volume. Mm-hmm. And those two things, and frankly, we just take every patient and we say, I'm going to take a big broad brush and say everybody's the same. Nana at 90 pounds and Tom at 400 pounds, they all just need to be between 12 and 24. And those are two totally different patients when you're talking about rate, when you're talking about volume and pressure. We haven't even added in our COPD population. We haven't added in what their intrinsic rate was when they started, before we even got to them. And now I'm trying to actually drive them to a rate that their body isn't used to.
And it's going to be deadly.
It'll be detrimental to their care.
I love, so the point I like using for reference ranges, because I'm a Chicago kid from the 90s. So Michael Jordan, the real GOAT, not LeBron. Yep. Coming out of school, we're told what is our normal heart rate, our normal pulse ranges.
Yeah, 60 to 100.
60 to 100, easy, right?
Yeah, but wait a second, stop for a second. It's 60 to 100, and as long as it stays within 60 to 100, you're normal.
Then you're fine. Michael Jordan's resting heart rate when he was playing ball was 33. I'm not going to try and pace the man. I feel like he can throw a punch, right, and yeah. I don't feel like hitting that. Reference range is grain of salt, a good stepping off point. So what are some numbers, right? So respiratory failure, I like to put it to school, right? You get a 58% on your test. You failed that test. You got some credit,
right?
But you didn't get enough to pass. And the same thing goes for respiratory failure, that you're breathing-ish. You were just failing to make the grade. You are not eliminating waste effectively, or you're not oxygenating effectively, or both of these things. You are failing to do it enough, right? Just like answering enough questions right on the test.
Right.
You got some, but not enough. What are some numbers you like putting to respiratory failure? Because it's pretty vague and ambiguous. Just say, hey, Rob, if they're not getting enough volume or enough pressure or breathing fast enough, it's failure. And you're like, oh, okay, great. That means, what are some numbers you like to put to observable signs? Because another one of my references is Denzel in Training Day, that it's not what you know, it's what you can prove.
Yeah.
So what are some things that you and I can both look at and see the same thing and both interpret as, that's respiratory failure?
Yeah, so I think that failure is going to be different in different people based on baseline metabolism. But for me, when you have decreasing SpO2s that are not being corrected, that are not correctable either intrinsically or if you're thinking you're correcting them extrinsically, then that is considered failure for me. As well as when you're talking about rates, sometimes rate can be the failure and volume can be the failure. But when we're looking at, are we effectively managing this patient, and do they need to get to a level? We talk in EMS. I want to be at 93% or higher. I want that number to be there. I'd love my end tidal CO2 to be between 30 and 40. And I know you're going to look at me and your viewers are going to look at me and tip their head and say, that guy doesn't know what the real end tidal CO2 numbers are. Actually, I'm talking about end tidal CO2, not PaCO2. PaCO2 should be between 35 and 45. Mm-hmm. Your end tidal CO2 should be between 30 and 40. It's a different number, but we don't drive that in school. We just say, if it's outside of this, then it's outside of the norm, and you need to fix it.
And then we're trying to fix the DKA patient whose end tidal is 60, and then we go kill them.
Right, and their end tidal is 60 and will be 60 and stay 60.
And this is the fun. I love end tidal. I can get on a whole soapbox about end tidal, but that 60 tells us things are going in the direction we need them to, and that's a good thing. Topic for another day, when you're like, what the hell is he talking about? An end tidal of 60 in the DKA patient? Yes, I'll take it. I want it. I will enjoy that all day.
And then the day before he met you, because he was having his day at the park or he still had an end tidal CO2 of 60. Mm-hmm. The other part of that is, and I'll just chime in behind that, when we meet people, let's just say I'm a COPDer and my intrinsic rate is 28. That's my rate. Mm-hmm. My rate is 28. If you try and make me 12 or 14, it'll be detrimental to my care. So when we're talking about ventilatory management, and again, we're talking whatever tool that is effectively managing that patient, where's my starting point? what was the patient's starting point with their respiratory rate? If it was 40, then guess what my rate's going to be? I'm starting at 40, and I'm rapidly going to bring them down into a range where my data points match their care points, which means it may be an end-tidal CO2 of 60, which only gets me an SpO2 of 89%, which is amazing for that patient, right? We're not driving to targets because your analogy of a test, you got 100 on the test when the patient had this patient's maximum SpO2 will be 89 and their best end tidal will be 60 and a good day. And I'm now trying to make somebody 6'2", 5'8". It's just not going to happen. It's going to be detrimental to their outcomes.
It's the mindset we come out of school with.
Yep.
That here's the normal ranges. You just got to get them to the normal ranges instead of making people better. But that comes from the conceptual competence of this, that the entry level expectation is 12 to 20. You get them 12 to 20. I like talking about the context of things. And we talk about, I love it in my sepsis talk that we talk about firefighters and rehab. They come out, their lactate's going to be high.
Yeah, absolutely.
Their respiratory rate's going to be high.
Yeah.
Excuse me, their body temperature's going to be high. Well, holy cow, we got serious criteria, Rob. That is a septic case. We better get them to the hospital.
Right.
Conceptually speaking, contextually speaking, no, they should be hot. They were just doing some manual labor in protective clothing designed to not let heat transfer back and forth. And yes, lactate builds when we're doing strenuous work. Yeah, so these are all normal things. And yes, they're breathing faster because their body's eliminating this little bit of extra. Guys, like let's not get locked into the words on this page of what it says. Let's understand this bigger picture in the context of it. So,
hey, look at Kevin. We I think sometimes in medicine for me, I look at things myopically. I look at, okay, my heart rate's good. Okay, my respirations are good. Okay, my end tidal's good. I look at things myopically, and unfortunately for us in pre-hospital medicine and medicine in general, our patients aren't myopically treating themselves with each individual thing. This is a holistic person that started with risk factors, right? That started with pre-existing conditions, that whatever this condition that I showed up in had already been running before I got there, right? They didn't forecast, hey, I think I'm going to have a respiratory event in 5 minutes. I'm going to call an ambulance, so they're here in 5 minutes, and they're here when I have my respiratory event. Usually, I'm behind the timeline, and when we look at that, we see I think there are some key components that we look at, and we say, okay, I need to fix this or I need to fix that. Your patient, when you look at them as a whole being. Did my heart rate come down after I did what I did to effectively ventilate? Where is the whole patient? I take my end tidal and I combine it in conjunction with my SpO2 and my heart rate and I separate my systolic and diastolic blood pressure because one is a squeeze and one is the pipes at rest. They both have huge differences. And I look at them independently, but I look at them as a whole now. I take them individually and I put them together and I say, am I effectively managing my patient? Am I seeing positive responses with this patient? Or do I just say, well, this data point is good, and this data point is good, and that data point is good. And if those three data points are good, maybe QA won't catch me.
Yeah.
Right? I'm not interested in catching you with QA. I'm interested in of your patients bringing you fruit baskets and telling you thank you.
Yep.
That's the ultimate outcome here, is your patient getting to the hospital and in 10 days, whatever amount of days they come back to see you, they're like, man, you effectively managed me as a person, not necessarily my IV, not necessarily my monitor pattern, like we do with when we test you, we just throw a couple monitor rhythms at. We're going to manage you. You managed me as a huge whole human being, and that's what saved my life, not you individually trying to fix things or. Again, just trying to avoid the QA net.
Treating to avoid QA, yes, that is a thing. Let's take this description of respiratory failure and let's kind of put a cap on it because we'll move into what we do about it. But our hallmarks are hypoxemia and hypercapnia.
Yep, high CO2
and low O2.
and low SpO2. So those are our number. Whatever one is above the other, and they're not within normal range, and it doesn't seem normal for this patient because I got a great history. And I know what this patient's history should be.
Yeah. I'm going to say, generally speaking, some things to worry about if we try to treat oxygenation and we can't get it above 90%. While at the same time, our end tidal starts creeping above 50, 55, flirting with 60, especially if we're watching it go up, right? History has us living there versus this person started at 50,
right.
And now they're at 70.
Correct.
we're watching that change. How do you feel about those numbers as general reference points?
No, that's fine with me, and I think that when you add that in, you're looking at what the patient's trending as. I don't care where you started, where you are now. Are you getting better? Are you trending towards a more positive response, or are you trending away? And if you're trending away, does it mean I need 500 cc's? Does it mean I need some special cardiac medication, or does it mean what really needs to happen is I'm going to go back and I'm going to stop and I'm going to look at the ventilatory support that I'm giving you, and is it effective? So the two things that we're going to see, Kevin, is a high CO2. So a CO2 greater than 40. Let's just use those numbers as our reference points, 30 to 40, and we assume that the patient's baseline is they're moving above 50, and our SpO2 is dropping down and is tanking below 90. Let's play those numbers. How do I get the first thing I want to do is I want to make sure I'm oxygenating the patient effectively with good ventilatory support. Now, sometimes the bag valve mask, independent of any other equipment, isn't effective enough. So I'm not effectively managing your SpO2 in this case. Your SpO2 is either maintaining or falling, and I need to better manage your SpO2. And we're going to take into account that you are effectively ventilating with a bag valve mask. You're squeezing the bag valve mask, and the air is going in, and the chest is rising, and I listened to it, and I heard it going in and out. The next question is, am I meeting the pressure requirements? So,
which are something to highlight, the two principles of oxygenation. This is a physics lesson. What are the two things that we affect to increase oxygenation into the body?
I can effectively manage your FiO2, which is the percentage of oxygen you're being delivered. The most common is I started with a nasal cannula, I raised the level to a non-rebreather, and I raised the level to a BVM, and now I'm running somewhere between 90 and 100% with FiO2.
So concentration.
Concentration, and the second part is PEEP or pressure support.
Pressure.
Which would be your CPAP, BiPAP, or PEEP.
So really, we either create a concentration gradient that a high concentration of oxygen only can go to the low concentration, which is in the bloodstream, hopefully, or we shove it on in.
Right.
There's oxygenation. In a nutshell, guys. Physics lesson. You're physicists now, right? We don't even need the names. I don't remember the names. Boyle, Henry, whoever. You're right. This is physics. That is, and we do this already. Just like you said, this person looks like they need oxygen. I'll put them on a non-rebreather. You're doing it, guys. This is fundamental, rudimentary principles of oxygenation. We either pressurize it, or we increase the concentration of it, or we do both. Right. So, okay, that's how we're treating hypoxemia. Yeah. Yeah.
And when we talk about those things, we tend to, I don't know that we've been taught how to troubleshoot. I don't really know. I don't know. So if you've got folks out there that they've decided the SpO2 isn't good enough and they want to increase the SpO2. What are there should be two things sitting right on the list that we just talked about. Is my concentration still good, or is my tank dry? And have I added PEEP or pressure support? Have I added PEEP, and is my FiO2 at a level that the concentration is effectively managing this patient? Those are my two problem solutions to the problem of hypoxemia. I'm going to do those two things. I don't need to do anything. I don't need a life-saving IV. I don't need anything else. I need to assure that I'm effectively ventilating you with FiO2 and pressure support. Those are the two things I want to do. And then the other part of that is hypercarbia. I've got an end-tidal CO2 that's excessive, that I know is excessive. Well, what if I add PEEP to a high end-tidal CO2? No, that corrects SpO2. Well, what if I increase FiO2? No, again, that corrects your SpO2. And how do I fix end-tidal CO2? Well, there's three ways to fix end-tidal CO2. I can increase my rate, I can increase my volume, or I can increase both. Those are the ways I fix my end-tidal CO2. Not squeeze harder, but I got to beta test this because every patient could be different. One patient could require me just to increase rate. Another patient, rate's going to be detrimental to them. They need volume. Maybe they need to be breathing at 8 times a minute, ventilatory support at 8, and a tidal volume that's 500, where somebody else may need a rate of 28 and a volume of 200. Right. These are the things that we need to, this is practicing medicine in the field. And your guys are going to be doing that with their bag valve mask ventilations and with their mechanical ventilators. They're going to have to solve these problems. And not all patients, I can't just put a template out there. You can't put something on the wall of the truck or on the top of the monitor saying every patient follows these rules, because every patient shows up differently with their risk factors and pre-existing conditions. Those are the two things that really we have to evaluate and effectively fix. You sat in a class and I talked about I get dealt a bunch of cards and I'm playing Texas Hold'em, and I look at this and I say, would I bet before I looked at my cards? Well, if I'd love to play against you if you bet before you look at your cards. I want to be a guy across the table from you. But would I bet before I looked at my cards? Did I really look at my SpO2 and then go and look at FiO2 and PEEP? Did I look at my end tidal and then go look at rate volume and rate volume together, both changing both of those? Did I do those things? And then when I asked providers, and I think I asked in the symposium, I asked a group, I said, hey, how long does it take to change these things? And I get some crazy number. Well, it takes minutes. It takes a couple hours. Does it? What is the pathophysiology of this? And I'm not a big pathophysiology kind of guy when it comes down to it needs to be done. Can you do it? I don't care if you can explain to me all the Boyle's law, Henry's law, Graham's law. I don't care if you can explain all. Can you effectively ventilate? How long does it really take to change an SpO2? Let's say I've got a patient with mild respiratory distress and they've got an SpO2. We'll just use SpO2 for this case of 89. And I say, well, and with 6 liters of nasal cannula, I can't really go any higher than 6 without making their nose look funky. I'm going to go ahead and I'm going to move to the next piece of equipment, which is a non-rebreather. So I go and grab a non-rebreather and I plug it on the patient and I say, I know their SpO2 is 89 and now I hope it gets higher. And how much time do I waste or how much time do I take before I go and reevaluate that, right? I changed my methodology of treating this patient. How long did I wait to come back and see, hey, did that work? Normally it's minutes.
I was going to say, it's one of two. It's either I looked at it immediately and didn't get a change, so I adjust things.
Right, yep.
Or there's an extended period of time because I went and started something else.
Some other task.
And then came back around to this eventually.
Right. And so let's get clear in if you're watching this podcast, which you are because you wouldn't have any idea what was going on otherwise, end tidal CO2. If you look at the end tidal CO2, it's a backwards 3 as an E. It's 3 seconds. 3 breaths, really. It's 3 breaths. 1, 2, 3. Look at your end tidal. If it didn't change, then change your technique. If you decided to increase rate, 3 breaths, and you look down at your end tidal, and if it didn't go from 60 to 59 or 58 and go from 60 to something, or went from 60 to 62, then you need to change to go from rate, change your volume. If that didn't work, then change your rate and volume. That's what we need to do to change that end tidal. It's 3 seconds. Why would I go start an IO when I want to know, did this piece of equipment work or not? Right? That's what I want to know. Now let's swing that around to SpO2. I've got that SpO2 of 89% and I went from a cannula to a non-rebreather. How long should it take how many breaths should that patient take before I look at that monitor and look at that data point and I say, I see validated change?
I'm going to say 5 to 6 breaths. I mean, we're looking at like 10, 12 seconds.
Yeah, 6 breaths. 3 breaths for end tidal change, 6 breaths. And I'm not, right, when I'm talking about breaths, I'm like, if I'm ventilating you, 1, 2, 3, 4, 5, 6. What's my SpO2? It was 89, Rob. It's 91 now. Man, you stay on time and on task. You got it.
And let's clarify this, that it's not 6 breaths to fix the problem. It's 6 seconds to see, or 6 breaths to see change in the right direction.
Right. I don't want to,
There's a difference.
Right. I don't want to go from 70 to 93 in 6 breaths. I want to go from 70 to 71. And I'm like, we're making progress.
We're doing the right thing. We just need more of that. We continue doing that.
Yep.
We're not, again, this is the school scenario. The problem's fixed. Move on to the next problem.
Right.
We don't necessarily fix problems a lot of the time. We don't get that luxury. Let's get out of the mindset of fixing problems and getting to the mindset of making things better. We're improving oxygenation. We're trending right. By the time we arrive at the ED, if it's 89%, okay, let's be honest. We're going to be received in the ED with, oh my gosh, it's 89%. What are you doing? And this is fabulous. They were 72%.
Right. Yeah.
10 minutes ago. This is great. Just like anything, you show them with the asthma attack. They were really sick. We got all the way down to giving them magnesium and the Dex and everything. And then the staff is, well, why did you give them all of that? They look like they're fine. Well, right, of course they're all fine because the therapy was effective.
So look at this, Kev. Let's talk about a patient with pneumonia. How long did it take for them to get in respiratory failure?
Yeah, it took a little while.
Yeah, it didn't take. It wasn't 5 seconds ago. It wasn't 5 minutes ago. It was probably days ago. How long is it going to take for them to get? If it took them a day and a half to get their end tidal CO2 to 70 and their SpO2 to 70, it took them a day and a half. You know how long it's going to take to come out of these woods?
No.
You didn't, unless you got airlifted out. And I don't know about a whole bunch of airlifting. And I'm talking about in a surreal way. It's going to take them a day and a half to get out. That's why these people, when it took them 7 days to get sick, they spend 7 days in an ICU to get well. We don't fix them and get them out on the street. We want to see, in medicine, we're looking for progress. If we're in medicine looking for perfection at the end of every call, and we've been given the perfect SpO2 greater than 93, end tidal between 40 and 60, a heart rate between 60 and 100. Look, man, if the heart rate started at 62 and it's 98 now, that patient is hurting and has been compensating, but we regard that as they're both normal.
I agree with you. There is I think we'd be remiss if we didn't talk about this one little point. There's a major contributing factor to hypoxemia or hypercarbia, that we list all these things in the book, and that it's the pathologies, it's the whatever else, it's this acute condition. What is this one factor that I want you to say, and I wrote it down on the list.
Hold on.
Spoiler. I set Rob up for this one. That one right there, right? What is this? What is the contributing factor that we tend to dismiss as causing some hypoxemia and some hypercapnia?
Then I would say that the number one issue that we're not addressing is the provider. The provider that's providing the care. And I'm going to put that in two different ways, because it's easy to say the person with the bag valve mask. That's so easy to say. It's easy to go, that guy right there that guy or gal who is not doing a good job. But let's talk about this. What if it's me going from a nasal cannula to a non-rebreather? And I'm responsible for this patient's care, and me not circling back around and saying, is what I did effective? Right? Because in my mind, and I've got a whole punch list of things got to get through. Right, my protocols say I put O2 on, I get an IV, I give albuterol. If that doesn't work, I give a combi vent. If that doesn't work, I give magnesium. And I got a whole punch list, and I got to run through this punch list. The problem with the punch list is the issue is the breathing issue started this whole thing. So let's spend our time, effort, and energy on, are we effectively ventilating the patient? And me I'm responsible for your care. I may not be responsible for the bag valve masking, because we never bag valve mask you. I'm responsible to assure that you're being effectively ventilated, right? It doesn't always have to come down to, I'm going to put a bag valve mask on you. Sometimes I believe I've gotten to places where I was forced to put a bag valve mask on because I failed to recognize that what I was doing wasn't effective. And I kept doing it because I met the need to my protocol. In that line, it says, apply high concentration oxygen. I went, well, I did that. So I met the need. But you didn't meet the patient's need.
This brings us right to what I like to call objective-based medicine. And what are we trying to accomplish? What's the actual desired end state? You're right, here's your protocols. The goal isn't put on a non-rebreather. The goal is not put a BVM on this patient. The goal is not squeeze the bag 15, 16 times.
Right.
That's not the goal. These are means by which we accomplish our goal, which is to adequately oxygenate and ventilate the patient. I think it's great when we talk about this provider technique being a consideration as a contributing factor, that it's not just the BVM technique. We're talking about all of this management technique. Because if we go put a non-rebreather on somebody, which ties back into your original comments about validating your findings, we need to know what findings we're looking for to then validate if we found them.
And I'm going to just jump in on you.
Come on.
And trend that.
Yes.
It has to be trended, right? Where did you start? Where did you end? And really, it's not on you. I don't hold. Sometimes patients, we do everything exactly the way we're supposed to, exactly, and they still don't do well. It just is. That's welcome to what you walked in with and what you walked into. But I want to be sure that it's not me. I'm the one that didn't fix the things that could have been fixed, that got you out of these woods, or at least started you, turned you around and said, we're going in this direction. We got 2 days to walk out of these woods. I'm the one that went, hey, let's keep walking deeper in the woods and climb these mountains, because I didn't validate what I had. I don't want to use the word competent. I'd like to use the word, I wasn't attentive. I have to be attentive to everything I do. I need to come back and say, did what I did work? And if it didn't, what am I doing next? But what has happened in my career is I did something because I was supposed to do it. And I didn't look at the large outcome. Am I making progress? Think about in ACLS. I'll use ACLS or any cardiac kind of care. We do a scenario where we do a mega code. What's the ultimate goal of the mega code? When we get done, we go, and the patient has a pulse and they lived and they went, no, I don't care if the patient had a pulse. But guess what? If they had asystole and they're in PEA when you got into the hospital, they're in a better spot to survival than they were when they started. Both patients don't have a pulse. Both patients are, quote unquote, dead, But those patients may have drastically different outcomes based on the progress we made to the point where we handed that off, or the progress we made to the point where we made a different decision that affected that patient's outcome.
Yeah, I like it. We're going to improve hypoxemia.
Yep.
With pressure and concentration.
Correct. Yep.
Right. We're going to address the high end tidal, which is inadequate ventilation.
Right.
With rate, volume, both.
Yes.
Our minute volume. And we need to understand that these are two concepts that are, man, they're somewhat intertwined. They're two sides to the same coin.
Right.
Of ventilation management. And they play with each other a little bit, not a whole lot. We start increasing tidal volume, then we start talking about airway pressures and some of these other domino changes, butterfly effect kind of stuff. But we're not pressure, concentration, oxygenation, rate, volume, elimination, ventilation.
Yeah.
And this is what we've been doing. Now we bring this machine in to augment the way that we do it. And let's not realize that it's not such a foreign concept.
No, it's everything that we've been doing. We just haven't put a tag on it and said, this is what you have been doing. So just a recap.
Yeah.
You said you talked about how to change our hypercapnia, our high CO2, how to change our SpO2 that's less than what we think is effective, right? I think that the keys to this are, how long does it take to change these? I think that should be an aha moment, that it's going to take me 3 breaths to change an end tidal. And I don't need to go drive on and do anything else. I need to stand there and stare at this machine and stare at this patient and look at this ventilator and say, 1, 2, 3. We were at 70, we're at 69. Man, that's great. Keep doing that. We're making progress. I don't need to see perfection yet. I need to see progress. And I think walking away, when we're talking about SpO2, we're talking about 6 breaths. When I should not go do something else. When you have a ventilator and you're playing with a ventilator, either the person that's ventilating or a machine, man, stand there and make sure that you're effectively moving in the right direction, and know that you don't have to wait a long time. You just wait for 6 breaths, look back and say, the end tidal was 70, now it's 65. We're on target, we're on time and on task. Now we can continue to drive on and continue to go back and check that, because if something tweaks out, patients get tweaky sometimes, right? They think something that was working no longer works, and maybe a rate of 16 and a volume of 450 worked for a while and was sending me in the right direction both ways with 8 of PEEP, was sending me in the right direction. And now things are starting to fall off. Maybe I may need to increase my volume and decrease my rate and increase my PEEP a little bit. All those things are practicing medicine. When we get to ventilatory management, a ventilator, a mechanical ventilator, the cool thing is it beeps at us.
Yeah.
The uncool thing with a ventilator, when
it beeps at us.
Yeah. With uncool things is, right, it beeps at us. And when you know what I do? I hit quiet down.
Yep.
Right? The uncool thing is, when I hand a bag valve mask off, it doesn't beep at me.
Yep.
And when I'm not doing well at it, I can't get a beep. I got a guy going, I got, and I say words like, hey, how's your compliance? How's your compliance? And usually the response is, good. They have no idea what I'm talking about, right? They have no idea when I say compliance.
And now that, how subjective is this, that compliance, good compliance for me, good compliance for you, good compliance for Scott over here, like, what's good? What's the measure of good, right?
It's so patient dependent, isn't it?
It is. It is, right? Provider dependent and it's patient dependent. We got a whole lot of variables playing into what this very vague description of it is. So it's not even you take out all of the levels of training and validating competence, all that stuff out. You get the most phenomenal technique of ventilating with the BVM, and this person is on point, giving it the right attention, and they say good. And then somebody else comes in with impeccable technique and on point and the right amount of attention, and they don't know what the compliance was on this previous provider. They can say good or bad or whatever it may be.
Yeah, compliance. Check it out. When you say bad compliance, oftentimes the term is the bag valve mask getting stiff. Mm-hmm. Right. Well, the bag valve mask can get stiff if you gave too much rate and too much volume. The bag valve mask is going to get stiff.
Or you didn't properly.
It has nothing. Yeah, it doesn't have anything to do with compliance. Compliance it's not airway compliance. It's your ability to. It's you. The problem is you. I think what I want to hit home as we're looking at wrapping this up, I want to hit home with your guys are going to get some mechanical ventilator training. Mm-hmm. And somebody's going to come in and say, hey, we're going to talk about some components. They're going to talk about rate. They're going to talk about volume. They're going to talk about pressure. They're going to talk about all these things. And they're going to think, oh, this is really cool. And most times when I teach ventilators, the providers are afraid. I don't want to hurt the patient. There's too many variables with this mechanical ventilator. And I come back and I go, man, all these variables were there beforehand, but you just didn't know it.
It is.
It's
like walking into the warehouse with a flashlight is kind of where we are with BVM education and knowledge. And we go put the mechanical ventilator on it because it has the feedback.
Right.
It has quantifiable feedback at that it's with end tidal, we got a little bit better. We know exactly what this rate is. Otherwise, sure, every 3 seconds, I'm squeezing every 5 seconds. Again, right? We get a little bit more quantifiable. But now this machine has deliberate control, has automated, not automated control, has our set controls, has the feedback, has the quantifiable feedback to it. You're right. The lights have come on in the warehouse. It's like in elementary school, I thought it was the coolest thing ever. When you showed up in the gym and the lights hadn't been on yet, and they turned on the lights and like the halogen bulb, they flash and then they get the glow and they start to get brighter and brighter. And
a little dusky first, yeah.
Right. Like that's kind of where we are. Is we're waiting for these lights to warm up, and you're right. It's all there. It's been there all along. And not only has it been there all along, we've been doing it all along. You know the patient with a low SpO2 gets oxygen. You put them on it. We just be a little bit more sciencey about it. And now we have a little bit more specific control of it, that we throw a non-rebreather on and it's what really is the FiO2 they're getting. It's more than room air. Now we have this machine that'll say, I want it at 70%. I will give you 70%. I will give you the 100% precisely. We gain some precision. Mm-hmm. But if we're not understanding conceptually what we're doing in ventilation management, it doesn't matter if it's this brand of ventilator, that brand of ventilator, this BVM. It doesn't matter. It doesn't matter if we go back to the old full-on ambu bags, right. The bag's way over at the other side and it's an arm's reach away. It doesn't matter. It's the concept of ventilating and oxygenating, and what machine we use to do it. We need to ensure that technical proficiency to accomplish these big concepts that we're going for.
Yeah, I really appreciate you guys getting these mechanical ventilators. We're also looking into mechanical ventilation. I'm gonna challenge. I hope I can get a copy of this. I'm gonna challenge my guys, and I'm gonna challenge your guys and anybody else that looks at this. You can say that this is an arrogant, selfish statement. If you need somebody to be ventilated with a bag valve mask, you can pick me. I will ventilate your patient with a bag valve mask. I will ventilate them as long as you want me to ventilate them, and I will do a really good job of it. Why do I say that? Because I've failed at it for so long that I've learned that is such a hinge pin of my care that I'm going to be really good at that. Mm-hmm. So when the scene is deteriorating on me, and I think I got to go back and check my airway and breathing because I learned that in EMT school, but I really didn't believe it. But I'm now believing it. And I come back to check my airway and breathing, and I'm looking for somebody to ventilate. When all the chips are down, and I'm looking around the room, and nobody really, I don't know that anybody's proficient in the room. The person that has to be the most proficient is me. And so if I'm not proficient at bag valve masking, if you're not proficient at bag valve masking, you really do need to find somebody that you're like, this is a mentor. Well, we send people off to get IV mentoring. And you know what? Your life-saving IV is not going to save your life, to be honest. But go find somebody that is really good at ventilating, at using a bag valve mask, really, really good at it in all circumstances, knows how to troubleshoot an airway, to manage a bag valve mask. Find those people. And if you're not that person, become that person. You have to become that person. Because when your mechanical ventilator doesn't work, you are the ventilator. Mm. Tag, you're it. And before you put that mechanical ventilator on, that mechanical ventilator is of no value. If for the last 6 minutes before that mechanical ventilator went on, that patient really received no ventilation, you're not going to get the results that you wanted. Mm-hmm. Find that person that is a great ventilator. And I mean that realistically. That sounds so, well, you know what? That's just, no. And I think we both have the same opinion. My opinion is show me, don't tell me. You can tell me all that you're a great ventilator. Mm-hmm. But you know what? When the chips are down, when we look around the room and say, okay, this guy, I can't get this guy's chest to rise. You want to be the guy that go, you're the guy that always gets this. You come here and do this. Or I want to be the guy to go, nobody can ventilate, really? I got it. No problem. That's not an issue, because that is such a key component. It really is. It is the key component of our care. And for me, please find somebody that can teach you how to do this. And it wasn't your EMT school. Maybe it was. Maybe you had a great instructor. It probably wasn't. and it wasn't your CPR class, and it probably wasn't your paramedic class. It's somebody out there that you know this person. You probably already know who they are, because when the chips were down on a scene sometime, they went, hold on. Give me that bag valve mask. And you're like, why is the paramedic, why is the AEMT ventilating? They should be doing other things. No, that's the person that climbs up there and went, this is that important. I don't care, even though I got a lot of other things on my list, this is that important that I'm going to be the guy that does this. And you know what? It may mean that other things don't get done because I'm not, it's not worth it for me to give this up because I haven't mentored other people to do this. So I'd love to have a scene that anybody on that scene, if I handed a bag valve mask to them, they would effectively, quote unquote, ventilate that patient. That's how it should be. Are we there now? No. Can we get there? I really believe we can get there. I think things like this, when we recognize where we have room for improvement, which is ventilatory management, when we recognize that, when we know the steps to take to correct that ventilatory insufficiency, when we have those techniques and we have proven it and validated with somebody that went, that is really, really good, you've done a good job, realistically with outcome-based medicine and not just box checking medicine, then I think we change the way we do business in medicine and in pre-hospital medicine, and we really do change our patients' outcomes. I thoroughly believe that.
I agree with it. And I think the way we get there, I mean, obviously training, practicing, being involved, skills lab is all important stuff, is this real-time validation that you've mentioned handfuls of times. You've got to be able to give and receive feedback. I'm married to an educator, and she regularly tells me that feedback is a gift. She's actually an administrator and gets to tell her staff that feedback is a gift sometimes. I get to hear feedback as a gift, but it is true. Feedback's a gift. I would like to know that I need to be doing something better instead of just failing at whatever this is and not know. I would rather have the awareness. And to take Chief Boker's comments just from yesterday is somebody has got to tell the emperor he's naked. It's got to happen, right? Otherwise, we're just out being foolish, and it's at the consequence of the patient.
It is.
That's the real loser, is this patient, not me, because, oh man, I got called out because Rob pointed out I wasn't paying attention to what I was doing, or that I should be improving the way this is going, or I'm not getting the result that I think I'm getting.
Or that I hurt your feelings.
Or you hurt me. Yeah. Somebody's got to tell the emperor, man. We got to have the feedback. You got to be able to take the feedback. It's tough. We're an ego-driven industry. But we need to have the humility, just a sprinkle of Kanye. Not a lot of Kanye, just a sprinkle of it is good. But we need to have some of that humility to take that feedback and understand what's going on. All this discussion of ventilation, effectively ventilating patients, talking about ventilators, and just so little talk about an actual machine.
No.
Right? So this is a conceptual thing. The machine is just going to help us accomplish our goals in this objective.
Man, I challenge you, get all that training on your mechanical ventilator. Take that training and put it into you as the ventilator, and you do what they talk about, the concepts in mechanical ventilation you apply to manual ventilation, and you'll see results. And you know what? You won't be so pressed to get to that mechanical ventilator so fast, thinking that's going to be the solution to the problem. The solution to the problem is really sitting in your hands. It isn't sitting in a box at the patient's head. The solution to the problem is in your hands. And if you can get those concepts, take what they teach you with that mechanical ventilator and put it into theory with your hands and get good at that with your hands, the mechanical ventilator just becomes an addition to give you your hands back.
Yeah.
Right? As opposed to, I got to get to the mechanical ventilator because my hands don't work well enough. We should never be going to a mechanical ventilator because we're not good enough at ventilating. We've already failed.
Yep, I think we're past that point. I agree. Well, Chief Atripaldi, I appreciate your time, your enthusiasm on this topic. I knew we'd get some good energy based on our conversations we've had on this before.
Yeah, man.
So thanks for being here.
Absolutely.
And I hope there's some good concepts that y'all are able to take out of this and put into practice in the way we ventilate people, and at the very least appreciating the opportunity we have in front of us to affect change in our patients.
Man, it was an honor. I appreciate being here.
Excellent. Thanks. Well, until next time, appreciate you listening.